Welcome this morning. This is the inaugural Brevard Business Briefing sponsored by Dean Mead. It is a type of meeting, a community gathering among the business community that we thought might be a good idea to sponsor, a forum where we can get together and talk about some subjects in a broad way that we frankly aren't talking about in the current places we get together and we chat. And talk about things that are critical to the business community, to Brevard County, and to its future. And do so in a way that isn't legalistic, but is community-oriented and oriented to Brevard County. We think this morning should be a tremendous discussion. We're very, very proud of the folks that have joined us to put on that discussion, and we look forward to it. It's our inaugural meeting, so we'll make some mistakes, but bear with us. We hope to have several of these a year, and look forward to seeing each of you again later this year. We have, at least I know, one public official I saw wandering around, Andy Ziegler with the school board. Andy, thank you very much for coming. And we also have, and I'd like to recognize, if everyone will stand, the lawyers with Dean Mead, both in Orlando and Vieira, Melbourne. Thank you. And so I'll just turn it over now to Claudia Haines. Claudia is the head of our corporate department here in Brevard County. Claudia is a graduate with high honors of Principia College, where she was in economics. She spent a good deal of time on Wall Street, then graduated from the University of Miami Law School cum laude, and has been a tremendous addition to our firm, and I think has done a great job in putting this program together. Claudia?
So good morning, everyone. Before we begin, I want to let everyone know that the discussion this morning is going to be videotaped so that people who can't be here can see it on our website. And I'd also like to mention that we have members of the press with us today. So for those of you who know us at Dean Mead, you know that we're business lawyers. We work at the intersection of business and finance and public policy and the law. Depending on our clients' needs, we're drawing from each of these perspectives and crafting solutions to the business law problems that our clients hire us to solve. As a result, on a regular basis, we're taking a deep dive into topics and business issues that affect our clients. Everybody okay back there? Okay. Recently, it occurred to us we might be able to facilitate problem solving on a larger scale beyond the specific needs of our clients by opening up a public discussion on topics that are of general interest. So this is our opening gambit, the Patient Protection and Affordable Care Act. It's top of mind. It's on the front pages of the newspapers. It's being rolled out across the country, and businesses need to be compliant by January 1st of next year. 3 years after its passage by Congress, the law continues to elicit passionate public debate and political discourse. So like it or hate it, local businesses are addressing the law's requirements in their strategic business planning. So even though the Affordable Care Act has become like the third rail of political discourse, we decided to tackle it anyway, because this is a game changer for our community. In Brevard County, a significant number of people are employed by healthcare entities. We have 3 major hospital systems, we have numerous related healthcare entities, and all of the services that support that. We're home to hundreds of small and medium-sized businesses, many of whom are deemed to be the large businesses under the Affordable Care Act. And of course, given our demographics, we're large consumers of healthcare services. This morning, we'll discuss the impact of the law from 2 angles, from the healthcare delivery angle and from the business and compliance perspective. Our panelists this morning are a hospital-based physician, Dr. Edgar Figueroa, a hospital CEO, Dr. George Mikitarian, a business CEO, Scott Sorenson, and one of our own tax gurus, Charlie Egerton, not just because we like to show off Charlie, but because huge portions of the new tax law are in the tax code. Our panelists have graciously agreed to take questions on the Affordable Care Act as it relates to their sphere of concern and professional expertise. So by exploring the law from these four distinctly different perspectives, we hope everyone will walk away a little wiser this morning. So just a couple of words about the format. It's going to be interactive. I'll be asking prepared questions of our panelists, but we're going to leave some time at the end for your questions, and we have a mic down on the floor. Panelists, it's not a pop quiz. So if anything comes up that doesn't yield an immediate answer, I'm going to park it over here on the flip pad, and we'll post answers later on the Dean Mead website. So no further delay. Let me please I'm going to introduce our panelists. Let me start with Dr. George Mikitarian. George has led Parrish Medical Center as the president and CEO since 2001. His tenure began with Parish in 1996 when he joined as the chief operating officer. Dr. Mikitarian is a fellow of the American College of Healthcare Executives with a doctor in healthcare administration and from the Medical University of South Carolina. He has a master's degree in health services administration from Indiana University School of Medicine and a bachelor's degree in health and physical education from Bridgewater State College. Dr. Mikitarian was named among the top most powerful people here in the Space Coast by Space Coast magazine. He's been named Citizen of the Year by Florida Today, and he was a Junior Spirit of Achievement recipient. Under his leadership, Parish was one of the first replacement facilities to be constructed using evidence-based healing design. Today, Parish is internationally recognized for its healing environment. Parish was voted America's #1 healing hospital by the Baptist Healing Trust for cultivating a culture of loving service for 3 consecutive years. I'd next like to introduce Charlie Egerton. He's one of the founding shareholders of Dean Mead, Egerton, Bloodworth, Capuano, and Bozarth. You'd think I could get that. It's my own law firm. He has more than 40 years of experience practicing tax and corporate law with an emphasis on tax planning for real estate transactions and representing clients in tax controversy matters. Mr. Egerton is admitted to practice before the United States Supreme Court, the United States Court of Appeals for the 11th Circuit, the United States Tax Court, and the state and federal courts here in Florida. Mr. Egerton is the former chair of the American Bar Association's section of taxation, the nation's largest organization of tax lawyers. He's been recognized as an outstanding tax lawyer by the Best Lawyers in America, Chambers USA, the International Who's Who of Tax and Corporate Lawyers, Florida Trend Magazine's Legal Elite, Florida Super Lawyers, the Orlando Business Journal, and the Orlando Magazine. Next, I'd like to introduce Scott Sorenson, a Brevard native, who's been the owner of Sorensen Moving Storage, an agent for Allied Van Lines since 1977. During the more than 3 decades that Mr. Sorensen has served as president and chief executive officer, he's grown the business from just 2 moving trucks and 3 employees to 215 employees and 36 long-haul drivers. The company is headquartered here in Melbourne, and is one of Allied Van Line's top agents in the United States. In 2009, Mr. Sorensen opened Sorensen Office Solutions, a full-service office furniture dealership. In 2010, Mr. Sorensen opened Sorensen Trade Show Services, a full-service exhibit and display company. Mr. Sorensen has received wide recognition for his entrepreneurial success over the past couple of decades. Recently, in 2011, Space Coast Business Magazine listed Sorensen Moving Storage among the Space Coast's 100 most admired companies. And of course, many of you know Mr. Sorensen through his gracious and generous community work for many local charities. In 2008, Mr. Sorensen was inducted into the Junior Achievement of East Central Florida Business Hall of Fame. In 2011, Mr. Sorensen received a Children's Hero Award from the Egerton Foundation for his support of organizations which benefit youth. Currently, he's serving on the board of directors for Junior Achievement, Preventive Brevard, the King's Center, the Brevard Zoo, and United Way. And last, let me introduce Dr. Edgar Figueroa, who is first and foremost a physician leader, a doctor who's dedicated himself to practice excellence and to the training and management of other physicians and healthcare workers in the delivery of high-quality healthcare. Dr. Figueroa is a fellow of the American College of Surgery and a diplomate of the American Board of Surgery. He's a trauma and an acute care surgeon employed by Health First at Holmes Regional Medical Center, where he served as the director of trauma and critical care surgery from 2003 to 2009. In addition to his surgical practice, Dr. Figueroa is a certified instructor of fundamental critical care support, training doctors to immediately assess the needs of critically ill patients and to manage acute, life-threatening conditions. He is also a certified instructor of advanced trauma life support, which is the standard of care for initial assessment and treatment in trauma centers. Since 2010, Dr. Figueroa has served in a formal physician leadership role at Holmes Regional Medical Center, having been elected by the 450-plus members of the medical staff to serve as one of its 3 elected officials. And he has chaired the Quality Management Committee at Holmes Regional Medical Center since 2010. And if our panelists would come up. Yes, you talk. Yeah, so in case those of you who don't know these fellows by face recognition, on my far left is Charlie Egerton, Dr. Figueroa, Scott Sorenson, and closest to me is Dr. Mikitarian. Dr. Mikitarian, the Affordable Care Act is supposed to make healthcare affordable, which implies that the costs are being driven lower through regulations. Could you help us understand where the savings will be or are supposed to be realized? So in particular, what are the primary components of the Affordable Care Act that's affecting your reimbursement model at Parish?
There's about an hour's worth of answers there, but just like the state of Massachusetts when it implemented its universal plan many years ago, the Affordable Care Act is not affordable in that no issues of cost reduction are inherent in the program. It looks at access first, thus the emphasis on ensuring the majority of the people that currently do not have formal health insurance. But issues of cost reduction and affordability really weren't the focus of the Patient Protection and Affordable Care Act. We somehow have dropped the 2 words patient protection, and I think there's a subconscious reason why that has been done over the last 3 years. Healthcare is inherently inefficient, in many aspects ineffective, and unfortunately extremely expensive. And there have to be a whole host of market changes, accountabilities installed to make healthcare affordable, as most of us would generally define that term.
So by implication, you're saying that the law itself hasn't actually imposed those types of rigors that you're suggesting would actually drive costs lower?
The way the system is designed right now, there's a conflict in the old way of healthcare delivery and reimbursement, in the new way of healthcare delivery and reimbursement. And the law, for those of you that are policy gurus, is an amalgamation of things that have been tried in the past, some of which have worked and some of which have not. The law is not implementable or even comprehensible in the way that it is written. It's inherent in its conflicts because it's still reimbursing providers. Providers are nursing homes, physicians, hospitals, and everyone else, largely for the amount of work they do. But trying to force us by law to become more efficient and effective and ultimately accountable for the outcome of the care. That is not just a legal transition that can occur by the implementation of a law. It is requiring inefficient, ineffective providers to all of a sudden shift the way they do business. So without consistency in the way providers provide care, without consistency in the way insurers price their plans, without demands for accountability from small and large employers, it doesn't matter what the government puts down on law. The system is going to have a difficult time in doing a 180-degree shift from where it is to the system that I think most of us would at least morally, if not philosophically, agree with, which is a system that is affordable and accessible.
But in the meantime, aren't reimbursement rates being driven lower in a regulatory environment? So you're being told, for instance, perhaps in your Medicare reimbursements or your Medicaid reimbursements, there's going to be fewer dollars available?
The quick answer is yes, but it depends on your perspective. You'll see many organizations, insurers included, pharmaceutical companies included, equipment companies included, that at the end of the day will end up making more money. It's simply a shift from my perspective in where the dollars will be allocated. You could conceivably enlarge the healthcare pie by definition or shrink it by definition. For instance, in the law, the word healthcare is used thousands of times, but nobody has defined what healthcare is. Is it clean water? Is it safe sidewalks? Is it lower speed limits on the highways? Or is it the actual provision of care from a provider to a patient? So until we have discussions around what the definition of quality is, what the definition of affordable is, what the definition of healthcare is, it's all just mumble jumble dollars coming from one person's pocket to the other person's pocket. So from our organization's perspective, and I would venture to guess from many others, if we become effective and efficient, like most of your businesses have had to become, there will be plenty of money to do the things we want. Why are hospitals still building brand new hospitals? Why are they building brand new office buildings? So we say one thing and we do another, but at the end of the day, there's enough to do everything that must be done. It's how we get there.
All right, so that's a great segue for Dr. Figueroa. So we've heard Dr. Mikitarian talk about quality of care, what is actually affordable, what does it mean to the patients. So from your perspective, so you sit on the chair of the Quality Management Committee at Holmes, you're dealing with patients day in and day out. What does it mean? What does it really mean, quality of care, to those of us who go to the doctor, who buy insurance policies, and who show up needing medical care?
Well, I want to start by thanking everybody that's here, because obviously start with you care of what's happening here, and it's and that's important. That's where it starts. Quality care, really very hard to pinpoint exactly what it is, but what it sums up to be in this day and age is going to be a commitment that is going to need to happen between hospitals, physicians, insurance carriers, and patients. The federal government has already decided what their definition is of quality care through the Medicare, CMS.
Explain that for us, for those of us who aren't.
Sure.
CMS, first of all, is the Center for Medicare and Medicaid Services, and it is the agency of government that's pushing the buttons on everything that goes into the hospital system, but in particular Medicare, which drives prices for everybody else.
Yeah, the Medicare, since they have such a big bargaining power over hospital, has asked hospitals to do one thing, to report on healthcare providers and systems by what they called the Hospital Consumer Assessment of Healthcare Providers and Systems, or HCAPS, which is how most of us know it when
And
we
this
talk
is the
about
quality measuring stick?
This is one of their quality measuring sticks, but it's probably the biggest one, because the Affordable Health Care Act is going to use this as their way of payment. They call it value-based purchasing. I guess we call it value-based payment. So if you meet their metrics, then you get paid a certain amount that they withhold and then are given it back. But in short, HCAP has different five matrix that are essential. Is, you know, they look at communication between nursing and the patient. They look at communication between doctors or physicians and the patient. They look at how hospital staff responds to the needs. They look at how you address discharges. Are they well informed? How do you address medication? Are they delivered on time? Do you understand, does the patient or the consumer understand what the medication does, what the side effects are? And I could go on for a long time, but I'll stop right there. I'm sorry?
I'm sorry. So there's information that the government is going to need to know. How are they going to get it? How are they going to get it? How does that information get from me or any of us up the information ladder, and that then it's going to come back down and inform how doctors are being paid? So what's the vehicle?
Well, hospitals have to report these. There is a reporting structure that goes directly to the federal government, Medicare. And this is now going to be, this is public information now. So any one of you can go and look at what each hospital does as far as HCAPs and where they fall within these parameters.
Now, isn't there also, though, a survey that's being distributed in hospitals to patients in order to report back up?
From the patient's perspective, they get survey, and sadly, I guess we accept that 40% return of these surveys, which ask all these questions, is appropriate. But the reality is, if from a patient's perspective and from a quality measure guide, if the more answers we get, the better it is for us to provide the appropriate care and tailor this community's needs to that, and obviously the hospitals and the outcomes. Quality of care is patient satisfaction in summary and outcomes. You have to be able to deliver both to be able to get paid again by the government.
Okay, now let's just switch now to the other side of the equation and talk about the business and compliance aspects. Scott, under the regulations, your company is an applicable large employer because you have more than 50 full-time employees. Can you share with us some of the challenges that you're facing as a CEO, executing on your business plan and complying with the new laws and regulations?
Mm-hmm. Sure. Let me just first say that as a small business owner, and we don't have 250 employees. We did at one point. We're at 70 employees, so that brings us closer to the threshold of 50. And as a small business owner, and you listen to what the two first panelists had to say, and you're a business person trying to survive in this environment, and with everything else that we have to be concerned with, I'll admit that I know the least amount of any of the panelists up here, so I'll say that. The challenges that I see, first of all, it's another burden on business to have to administrate and keep track and watch what the threshold is, what the minimum is that we have to meet with each employee. And for the small business owners out there, I had a cram course on this. We have to meet 9.5% of the gross pay in order to be in compliance with providing health insurance.
Do you have a feel yet for what those costs will be to your company? Not yet? No,
because truthfully, it's a moving target. We do know that in our company that through the year 2014, we're secure with our cost. Beyond 2000.
Meaning that the product that you'll deliver to your employees will be compliant and it's baked into the cake already.
Yeah, we've already been told by our health insurance company that we will be in compliance through 2014, and I believe that one of the reasons I haven't gotten totally engaged and studied it like these guys here that are much closer to the issue is because it's a moving target. Like I said, it's going to be, I think it'll be amended to some degree. And
Are you doing anything yet with employee communications? Are your employees asking?
No, not yet. I feel personally it's too early. First of all, again, we're secure for about the next year and a half. So there's no need to start informing people until we know what it's really going to look like in the end. I can say that for a company like ours, we're going to continue to move forward. If I was at employee number 49 and I had to get to 55, I would hire the 55th employee, because we're in business to expand and to grow. But smaller employees, it's going to put a huge squeeze on smaller employers, on small businesses, and candidly, I would say that we're trying to insure more people. This is going to work to the opposite spectrum when it's all said and done, in just my estimation, because smaller employers aren't going to be able to afford this, and nor will the employees that work for those smaller employers.
So Charlie, maybe you can get us into some of the nuts and bolts now, what it is that businesses like Scott's are going to have to do. So we're hearing everything about the personal mandate, the pay or play rules. Can you walk us through all that simply?
Well, we really have two mandates in the Affordable Care Act. We have the individual mandate, which says every individual must have insurance or pay a penalty. And we have the employer mandate, which says that if you are an applicable large employer, which means basically an employer with 50 or more on average full-time employees throughout a measurement period, then you have to offer an employer-sponsored plan that has what they call minimum essential coverage to all of your full-time employees and their dependents. And just as a quick digression, dependents do not include spouses. They do include children up to age 26. Why that came in, I am not entirely sure. But anyway, that is basically the law. The objective of this is to expand the universe of insured individuals so we can spread the cost, because part of this is that you cannot refuse to accept for insurance coverage anyone who has a pre-existing condition, and you cannot impose a lifetime maximum on individual covered employees. And both of those involve costs, and if you're going to be able to make that work, you've got to spread it over a larger group of people. Whether this will work or not remains to be seen. For individual coverages, of course, each state either has to establish a health insurance exchange, or if they don't, then the federal government will establish one for you. In Florida, we started off down that road a few years back, but when Obamacare was passed, Florida opted out. So we have basically advocated and allowed the federal government to establish this exchange for us. There are two penalties that can be imposed. There are alternative penalties. If you don't offer a plan at all to your full-time employees and dependents, you basically just opt out of the system, then a penalty is imposed, and it's $2,000 per full-time employee. It's actually $167.50 a month because it's levied on a monthly basis. It is a tax, it's an excise tax, but most people refer to it as a penalty. If you think about it and you compare $2,000 per employee, by the way, the first 30 full-time employees are exempted from that penalty. So it's only your full-time employees in excess of 30. But if you run the math on that and compare it with the cost of providing health insurance coverage that meets the minimum essential coverage, it's much, honestly, cheaper to pay the penalty.
But that's just the first year. The penalties, do they go up?
Penalties will be inflation adjusted, and by the way, that's not CPI adjusted, that's medical inflation, which translates into a much higher percentage.
George, what is medical inflation? Do we know?
It tends to be 2 to 3 times higher than the general consumer price index. inflation.
Okay.
So that's a major change that's going to come about. Then there's a second penalty. And this is if someone establishes, sets up an employer-sponsored plan that has the minimum essential coverage, but one or more of your full-time employees opts out of the offered coverage, buys insurance on the new health insurance exchange, and qualifies for premium assistance or a premium credit. Now, that's fairly easy to qualify for because it's anyone who's making up to 4 times the federal poverty level, which means somebody could be making up to $92,000 or $93,000 and qualify for some premium assistance.
But that's a family of 4. Family of 4.
Right, I'm
92,
sorry,
right.
that is. But if you have one person, one full-time employee that does that, then the entire penalty gets imposed.
All right, so just to clarify that example, the point is that there are 60 employees in a company. The company is an applicable large employer, is subject to the pay-or-play rules. Somebody falls between the cracks because of a compliance miss at the company. They go to the exchange. They qualify for a tax credit or a subsidy. Now the company's going to get a nasty letter from the IRS saying, by the way.
The first thing is it's certified that one of your employees has
Right.
bought insurance and qualified for assistance.
And so the IRS comes back to the company and says, by the way, you had somebody who fell between the cracks, and in order to teach you a lesson, we're going to apply a penalty, but we apply it across the board on all employees.
Okay, now here's the
Go
thing.
to the math there.
If you have offered a plan and somebody still goes and qualifies, which can happen if you don't meet what they call a minimum value standard or an affordability standard. There's actually a third way too, because even though you have to offer this to all of your full-time employees, they do have a 5% slippage. And somebody could be in that 5% and qualify. So any of those 3 situations could arise, and one of your full-time employees goes and buys insurance on a health insurance exchange and qualifies for premium assistance. If that happens, then there's a separate penalty that is imposed. And it's imposed only per full-time employee who does that, who qualifies, and buys insurance on an exchange and qualifies for assistance.
Fair to call it a compliance nightmare?
Yes, and that's $3,000 per employee. There is a cap that if enough of your employees opt out and do that and qualify for assistance, the total penalty can't exceed the first one, which is the $2,000 for your full-time employees over 30.
Are these tax deductible?
No.
Okay.
It's pretty
It's being
complicated.
paid out of after-tax dollars. So, I mean, it's complex. You want to make sure, if you're going into this, that first of all, you understand whether you're subject to these rules. And if you are subject to these rules, then you need to count the cost of compliance and make a business decision.
No, we hear, everybody, we talk about amongst ourselves at Dean Mead this July 1 date, but you don't read about it in the media. Explain to our guests here why we talk about July 1 in terms of business taking a snapshot and taking a look at what they're doing to prepare for January 1st, 2014.
Okay, all these tests, which are tied to whether or not you're an applicable large employer and whether you have more than 50 full-time employees, all of this is determined on a look-back basis. So even though the date of implementation of this on the employer mandate is January 1, 2014, the testing data that is going to be used to decide whether you're in or out is occurring right now in 2013. What happens is there are several different periods involved here. There is first and foremost a measurement period, and that's determined whether you have 50 or more full-time employees. Who are your full-time employees? There's also something called a full-time equivalent, which we'll get into later. But are you in or are you out? And you can basically, particularly they have some fairly generous transition rules as we work our way toward January 1, 2014. And you as an employer can pick your measurement period. The measurement period must start no later than July 1 of 2013. So we're rapidly approaching that point. You can make it 6 months, you can make it 90 days, but whatever you do, there's also a stability period. which is, okay, when we get to January 1, 2014, whatever your measurement period is, we're going to determine who's a full-time employee, who's an applicable large employer, whether they're in or out, and then how are we going to apply this going forward. Once you determine during that measurement period that you have more than 50, or 50 or more, I should say, then you must, throughout the stability period, offer this insurance coverage to your full-time employees and their dependents. And that stability period will continue for the greater of 6 months or the time of your measurement period. And essentially what that means is once we stamp this person as a full-time employee, unless that person leaves your employment, you must offer that insurance coverage to him or to her and to his or her dependents.
Okay, I'd like to, we're going to take it back into the healthcare delivery realm. And if I could have Laura Young and Christine Weingart have taken a look at what the Florida legislature dealt with in the last session as it relates to this topic. And in particular, the reason why we're bringing this to everybody's attention is because there was money offered to the state of Florida. It would have gone to Medicaid. It would have eventually found its way through the system, and we just thought we'd just do a quick legislative update.
The Florida legislature had, of course, many things that it faced during the session. The two important ones that dealt with the Affordable Care Act, one Charlie mentioned, which was the exchanges, and Florida has opted out of the exchange for now, or they haven't decided on it for now. But the other one was Medicaid expansion, whether or not to expand Medicaid. What the Affordable Care Act did was it gave the states the opportunity to expand the number of people that Medicaid was provided to. It allowed them to lower the age from below 65 to those people who earned up to 138% of the federal poverty level. It went to state of Florida. State of Florida batted it around. The House provided a alternative to taking the federal money and coming up with their own system. They have not decided on anything yet. The expansion of the Medicaid program was denied, so it's still on the table. They're batting around a few lower cost alternatives. Still, one alternative is to accept the federal dollars at some point, but for now it's on the table, and they may decide to do a special legislative session later this year, but that's still up in the air as well. And Charlie mentioned the exchange, the other part of the Affordable Care Act that the state legislature was batting around, and that's still on the table as well.
Thanks.
That's it.
Okay, so just to summarize, Charlie mentioned if your employees go to the exchange is designed under the Affordable Care Act to address uninsured individuals and small businesses. So it's supposed to be filling a gap, and that as yet is still up for discussion because it just hasn't been dealt with. There's an October 1st deadline under the law, so we don't know yet what's going to happen by October 1st. What I wanted to ask George, though, is what's the significance, or not, to Parish or to any of the hospital systems, but specifically to Parish, by the Florida legislature's refusal to expand Medicaid?
Understand that people still have access to health care. They just access it sometimes at the most expensive place, which is our emergency departments. So from that perspective, when we talk about will Florida participate or not, it's not that we're preventing people from receiving basic health care. They are. It's the matter of who pays the bill. At the end of the day, every physician, every nursing home, and every hospital, any provider has to charge those who pay more to cover for those who don't pay. So whether it's done through the state Medicaid system, the federal Medicaid system, or not having a state Medicaid system and people coming to our emergency department, you all still pay. So call that a penalty, call that a tax, or we could argue that maybe you should all be paying a little bit more so the state can afford to provide health care through a formal Medicaid program. Either way, the dollars, again, are the same. It's a matter of what you call it. So the state of Florida doesn't produce anything that generates revenue. It gets its revenue from us. So whether the state pays or doesn't pay, it's still coming out of our collective pockets to cover these people that are accessing our emergency departments. So again, it gets down to your philosophy. Do you believe that everybody should have, as a right, basic level of health care, as we provide a basic level of education? If you do, that takes you down one path. If you don't, it takes you down another. But at the end of the day, it's costing all of us essentially the same amount of money. It's a matter of where the money goes, who collects it, who distributes it.
So you're agnostic. You guys are going to collect it irrespective.
Yep.
It's not.
Yep, I'm gonna get it out of your pockets. If the state doesn't come through the Medicaid system, or the state will pay me 30 cents on the dollar for the privilege of providing health care to people.
Dr. Figueroa, I never call you that. Can I call you Fig? Right.
Everybody calls me Fig.
Yeah. So taking that from what George has just described us, as you know, patients can't be turned away. And if the patient traffic is still going to be driven higher in the hospitals, either because of deficiencies in the system that's trying to be developed, or the mere fact that this is the pattern of behavior by consumers, they're going to walk into an ER. How is it then that the doctors are supposed to be delivering the quality care? And are the patients going to know the difference? I mean, is this something that's being talked about at a higher cerebral level, whereas those of us who actually access healthcare, it's like same old, same old? Are we going to know anything different?
There's a lot of difference. I think for the first time, we're talking about making sure everybody is on the same team, making sure we cross-check each other, making sure that we create standards and create standardized protocols. And at the quality level, we're trying to standardize care by creating protocols that really are process-driven and not people-driven.
Is that as a result of the law, or was that going on anyway?
It's in preparation for the law. And there had to come a time when it needed to happen, and it's great that it's happening, because patients will see the difference. You know, if your thoughts are that what your end goal is going to be is to get the care that the patient needs at the right time, doing the correct diagnostic studies and procedures, and delivering better outcome, how can that not go unnoticed?
All right, so that's an argument for changing the doctor's headset.
Yeah.
I wanted to I have lots of questions, but I wanted to leave time for you all to ask questions. So I'd like to open the floor, and if you don't have any, I can keep going. Please.
How do we know what healthcare costs? Because the current system, you get your bill back from the insurance company, and it says the MRI was $1,200, but Aetna paid $322. And that's the chart. It's kind of what it seems to me every time I go for healthcare and look at the cost, I can't make a choice as a consumer. It's kind of like the placard on the back of the hotel room on what they can charge for the hotel room. So when is the patient or is the patient going to come in as a consumer of healthcare in this system, or is it still just going to be, as I see it, a contract between the insurance companies and healthcare providers, and the patients pick up the tab?
So George, maybe you can handle that one. That's the cry for transparency.
The reason you don't know how much it costs is because providers don't know how much it costs at the end of the day. They can argue all day long. They have these fancy-dancy computer systems that will tell them how much it costs to treat patient A and patient B, but nobody knows. There are so many inefficiencies inherent in the system that if I deal with a Blue Cross patient I've got reams of different kinds of paperwork than I have with a Cigna patient. And hospitals typically have 1,000 different payers that they're dealing with. We have different relationships with different providers. Some physicians are employed, some physicians are not. A physician who is not employed by Parrish Medical Center can walk into our hospital today and, by the use of his or her pen or the use of his or her computer, order so many tests on a patient that it will take me literally months to finally calculate how much that physician ordered on that particular patient. So if an x-ray is ordered on Monday, it costs me a different amount for that x-ray than it does on Tuesday, because I have different staffing, because I have a different amount of patients in my hospital on that day. I have a different number of physicians in my hospital on that day. So literally every patient cared for every day costs a different amount of money, and there is no way to calculate it. So we play this hidden game with you by having what we call this charge master that does not reflect our true costs. And all we do is negotiate percent discounts off of contracts with insurers that we think covers our costs. But at the end of the day, we know that Medicaid pays us about 30 cents on the dollar, and Medicare pays us about 80 cents on the dollar. So all we do all day long is try to get as much as we can out of the commercial insurance companies to hopefully, maybe someday, cover that gap. And it's a constant cash flow game. There's not a hospital in this country that knows how much it costs them to provide a particular service or program, regardless of what they tell you, and therefore it's a race to the top to see how much they can get, because they don't understand what their margin is or how low they could go. So that's the inside skinny to that.
Once the decision was made by the government to provide access to insurance so that everyone can get access to care, what will that do to the initiatives that Health First and Parish, I know, have done to try and reach out to the poor in the community to access care? Is there any reward given for the HOPE program at Health First? And I'm not sure how Parish is involved, but reaching out to the community to provide health care. Is there any incentive to continue that now?
Yeah, the incentive is we get tax-exempt status. Hospitals, generally, there are some for-profit hospitals. Gustav Health System is a for-profit hospital. But by law, by IRS regulations, organizations like Health First and Parish that are tax-exempt must provide a certain amount of community benefit. That's bad debt, that's charity, that's benefit-free to the community in order for us to keep our tax-exempt status. That's the dirty little secret about why hospitals do all this community stuff. It's so we comply with our tax-exempt status. So we save millions of dollars on interest saved on the bonds we issue. We don't get charged by our cities for property taxes by keeping our tax-exempt status. And the tax attorneys will tell you there's IRS laws that basically say how much of that we have to do. That's really, at the end of the day, why most tax-exempt organizations do that.
And will you have to continue?
If I want to maintain my tax-exempt status, yes. And in fact, the IRS, for the first time in probably 40 years, is getting ready to make those burdens for a proof of tax-exempt status even more stringent.
I have two questions. First is, how does the ACA define a full-time employee? And second, if under the opt-out rules, if an employee takes at their option to enter the exchange, it sounds like the ACA is asking the business owner to bear the burden of providing better value or lower cost or better care to that employee. And so how can a business owner really find that sweet spot to prevent an employee from opting out and therefore penalizing his employer?
Okay, the definition of a full-time employee under the Act is anyone who averages 30 hours or more per week. Now, the normal model, if you will, that most of us think of is 40 hours a week for full-time employment. But the Act specifically defines Full-time is an employee who averages 30 hours or more per week during this measurement period. Okay? So if that person is a full-time employee, and if you're an applicable large employer, then the rules are that you must first offer an employer offered or package plan that meets what the federal government calls minimum essential coverage. That's 10 different areas of coverage. And in addition to that, you must provide minimum value and affordability. And what those mean are, number one, minimum value, basically the employer has to pay 60% or more of the projected cost of providing the health insurance benefits.
Which is an actuarial value, isn't it?
It is.
Which is why it's complicated.
But according to Kaiser and actually the studies from the Department of Labor, 98% of employer-sponsored plans right now meet that standard. So that's probably going to be fairly easy to meet. The affordability is another issue, and that is, and you look solely at the full-time employee himself or herself, and if the cost to the employee to obtain this coverage, to buy into your plan and buy coverage for him or her, does not exceed 9.5%, and the term is of his or her household income. Now, that's almost impossible to determine, frankly. It's a special definition, so they set up 3 safe harbors. It says you don't have to get involved in that. You can pick one of these 3. One, you can use the W-2 income for the employee for that year. And if their out-of-pocket cost to obtain this coverage is going to be projected to be 9.5% or less of W-2 income for the year, you're fine. You meet the affordability test. You can also adopt the federal poverty level and use 9.5% of that. So, you know, whichever is the cheapest, whichever is the easiest. There's the third that's kind of an amalgam of different things that I doubt people are going to use that much. Those 2 are probably the best alternatives. If you offer a plan as an employer, you're an applicable large employer, you've offered a plan that meets the minimum essential coverage, your insurance company will tell you whether or not you meet that. That's fairly easy to determine. And you meet the minimum value and the affordability. If your employee opts out and goes to an exchange and buys it, that's not going to cost you anything, because that person just basically turned their back on the coverage. You met all the requirements. You're not going to be penalized for that. It's only the people who are going to get caught are the ones who offer the plan but don't meet either the affordability or the minimum value requirements that are going to be paying that $3,000 per employee penalty.
Charlie, is there a W-2 reporting requirement for these employers?
Yes, there is. And by the way, Scott, going back to a comment you made earlier, there's another critical date, and that's October 1. And October 1, whether you're an applicable large employer or you're not, you only have 2 employees, you still are obligated to inform all of your employees of the availability of the health insurance exchange. And if you're offering employer-sponsored health insurance, you've got to give them a whole breakdown of exactly how much it's going to cost and whether or not these standards are met. And the Department of Labor, I think earlier this week, came out with a suggested form to comply on that. So you do have to, as an employer, you have to inform your employees on October 1. I think there's a grace period in there.
And we know why they want to do that, right?
Yes. The exchanges, by the way, will become up and operative on October 1. And I should say the exchange, because we're in Florida. There will be one exchange. And by the way, I don't know this for a fact, but I've heard that the transition problems are so complicated, we may only have one insurer included in this 2014 exchange. I hope that's not true, but that's a possibility. The idea of these exchanges is that we'll create a marketplace of products, insurance-backed products that will meet all the requirements and hopefully at a more affordable level. That's the theory of it,
Yeah,
whether that works or not.
The exchange is supposed to offer what's called a bronze level plan, and the bronze level plan has got an actuarial value of 60, what Charlie was just discussing. And the idea, of course, is to bring together in the marketplace other insurers who are able to offer this plan so that there is some transparency and pricing, but so far we don't have that. Are there other questions? Claire?
I just had a quick question, a follow-up. You mentioned that the employee's cost cannot exceed 9.5% of the household income. Is that for the employee's health insurance or employee independent?
No, it's just the employee, the full-time employee himself or herself. That's the test.
So by offering, the employer offers to pay 100% of the employee's cost of the insurance, we have that covered.
Yes.
Okay, just checking. Thank you.
If you don't mind doing that.
Yeah.
I hear about waivers, companies getting waivers. What's that about? How do they qualify? Why are they seeking waivers?
I heard it. Do any of our panelists have a response on that, or do I need to put that in the parking lot?
I don't know specifically. I know that there are some exceptions if you have grandfathered plans.
They're mostly large unionized companies, and part of the negotiation for the Accountable Care Act was negotiations with unions. Many unions are exempt from a lot of the requirements that he's mentioning. So the large employers that have large populations of unionized employees are the ones who have been given the exemptions by the government. Read into that what you want.
That's fair.
Obamacare.
Hey, Scott, do you think that this will be a drag on small businesses? That are 25, 30 employees, and do you think they're going to not try to expand and not hire as a result of this? And then Charlie, maybe you can comment on the aggregation rules where somebody may try to avoid the law by having separate entities and having so many employees in each entity.
Well, Rob, I do think that it's going to be a drag on smaller businesses. As I said earlier, I think a company like ours that we're going to continue to go forward and try to grow our company and do the right thing. And at the same time, also looking out for the welfare of our employees. That's important too, and being competitive in the market from an employer standpoint. But absolutely, employers and employees that are with employers that are below the 50, I truly believe that they're going to have a difficult time with this. And employees are going to have a difficult time. There's going to be a squeeze on those people, and I think in that category, there's going to be a rise in uninsured people. And then, if you put all that to the side and you try to figure all this out as a small business person, it's exhausting. Then you got to still go try to make a profit and give good service and all that kind of stuff. So it's gonna. I think it'll be difficult for some companies. I do.
Well, Rob, on the questions you raised there, that Congress anticipated people were going to try to game this somewhat to avoid being an applicable large employer, and they sought to plug two loopholes. One is if you've got employees who are working on average 30, 31, 32 hours per week, well, let's just cut their hours down to 25, 29, and make them no longer a full-time employee. Well, one aspect of the law is they say, okay, in determining whether you have 50 or more full-time employees, we're also going to take the aggregate hours worked for non-full-time employees. We're going to total these all up, not taking into account more than 120 hours for any one employee in a month. And we're going to divide by 120 and come up with some fictional full-time equivalent employee. And we're going to add those full-time equivalents to your real full-time employees to see if that pushes you over 50. And if it does, then you're an applicable large employer. Now, you don't have to offer coverage to these part-time employees, but that can be enough to push you over the line to be an applicable large employer.
And when they do the counting, they're looking not only at the company, but affiliates and subsidiaries?
That's
Isn't that
point
the
number two.
aggregation?
The other possible gaming of the system is that, you know, if I've got one organization and I've got 60 full-time employees, why don't I divide into two organizations, each with 30 employees, and presto, I'm no longer an applicable large employer. Well, Congress basically adopted wholesale a system that has been used to prevent discrimination on plans, employee benefit plans. And what they do is they aggregate any affiliated organizations. And the definition of affiliated organizations is extraordinarily large. They use attribution rules if you have commonly controlled businesses, or if you're operating as an integrated service organization offering together certain services to an entity or to an end user, that's treated as one employer, which means we take all the employees of all these affiliated organizations and we determine whether or not they're over 50. If they are, each one stands on its own and has its separate penalty and, imposed and so forth if it does or doesn't comply. And you have to allocate that 30 employee freebie, if you will, among the affiliated group based upon the number of employees in each. But that's two ways that Congress anticipated people would try to do an end around this. There was an interesting article I want to call your attention to. It was on the front page of the Wall Street Journal and yesterday's Wall Street Journal.
Right, the mini plans.
And these are, there are a number of insurance companies that are putting together packages of employer-provided plans that would technically meet the minimum essential coverage, which gets you past that first $2,000 per employee for your entire census of employees over 30.
Although the article was clear and they were saying it's a game. Nobody's sure it's going to be enforceable.
And you know,
So
anybody that's trying to
it's a
skirt
risk.
the edges like that, you always have a big red flag.
Right.
Certainly, a lot of people in the Department of Labor and Internal Revenue Service and Homeland Security, the three
Read the Wall
agencies
Street Journal,
who
right.
read the Wall Street Journal. And so
I wanted to take it back to FIG. Scott was talking about how this is likely to affect employment in the private sector. What do you see at the hospital? Do you see employment pressures or changes in employment at the hospital level, even in private practice, as a result of these laws that are now being implemented at the hospital?
Well, what we have seen throughout is pretty much the purchasing of physician offices and groups incorporating into hospital.
Meaning that there's now the pendulum is swung,
There-
so private practice
there.
physicians are joining hospital systems as
That
employed
is correct.
physicians.
That's correct. And for how long, and obviously this is all in preparation to deliver the quality that you need to, not lose money.
But isn't it also a reaction to the concern that the private practices may not be as profitable or can't comply? So isn't it for a doctor, why not become an employee rather than hassle with being a small business?
Well, I mean, there's plenty of articles in our throwaway journals regarding that effect. The fact is, physicians get paid less as outpatient or community physicians as if they were hospital employees. And the reason for that is hospital get a 44% higher ability to pay than if you're doing something as an outpatient
So in
procedurally.
consumer speak, what you're saying is if a patient goes into a hospital, the doctor delivering the service at the hospital has a 44% higher reimbursement rate for the same service, which goes back to the transparency question, as doing it.
Well, I mean, and that's what the articles come to. There's a couple out there. I believe there was one by Forbes that was from 2 months ago regarding that. There's one in this month's General Surgery News talking about the same thing. But I guess most of it are talking about you got a CAT scan taken as an inpatient versus a CAT scan that's done as an outpatient facility, the difference as far as billing comes out to 44%, is what these articles are saying. And you know, I don't know those numbers. I'm just telling you what the articles reflect to. But but there's more to it than that. I mean, we're talking about the ability. This is really a survival mode, and what we're talking about for everybody has to be in a survival mode. What the Affordable Care Act doesn't do effectively is separate risks. It actually just throws it out there, and right now, most of the risk is really allocated to hospitals and physicians. And patients have very, very little risk to deliver, when in fact, most of it is centered, and most of the quality measures or that they look at is centered on the patient being satisfied with the care they're given and obtaining the right outcome. So there's nothing in the Affordable Care Act that really allocates risk to those different players. So at least the way I look at this, or the way I see it, is the government is basically saying, here's enterprise, you guys teach these people how to take care of themselves. So you guys come up with the preventive medicines, give everybody flu shots. And a lot of that is coming around, which is beneficial, obviously, but is an additional burden on hospitals. There's going to be an additional burden on employers of having to carry these insurances, because part of the fix would have been a better education system of the patient. An educated consumer actually contributes a lot more. Like I said about surveys, if everybody would have returned a survey of your hospital experience, it's much easier to provide a much better quality of care than it is if you're kind of guessing what these people that didn't answer, were they satisfied, were they unsatisfied? So.
Well, I have time for one more question. I have a question from the Parish side of things. I had read recently, I believe in the paper or on the internet, that Health First is now offering private pay insurance plans for individuals in the county. And that is, I think, an option for some of the small businesses who are underneath the 50 threshold. Did I see that correctly in the paper or on the Health First website? And is Parish looking at following suit? If that was
We don't have an insurance plan.
Yeah, that is correct.
Yes. Okay, so that might be something for small
It was
businesses
in Space Coast
to talk
Business
to
or
their
something.
employees about if they're underneath the 50 employee threshold, that if, as a consumer, I'm trying to find coverage in Brevard, I can go to the employees and say, we're underneath 50, we cannot offer coverage, but go through to the Health First website, you can see all of the different plan options that you can buy into as an individual, and that would keep them out of the state fund system, correct?
I don't know.
There's a small business credit too.
There is.
That if you're.
You get 50% credit.
Yeah. If you're 25 or fewer employees and your average compensation is $50,000 or less, you could get a credit toward the cost of providing insurance to your employees.
The IRS actually has a tremendous amount of information available. In fact, there's a website called Small Business Healthcare Tax Credit, and if you just type it in, you'll go directly to the IRS fact sheet on that, and it will tell you about it. In fact, there's a lot of resources. It just takes a ton of time to collate them and collect them. A nice place to go for just a really in-depth summary is the Kaiser Family Foundation, kff.org. As I said, the IRS has got information. Are we done? We're all out of time here. Okay. I want to thank our panelists. Thank you very much.